What did her strength look like from week 2 to 4? So, like I said, she was non-weight bearing until week 4, which ends up being a big problem because, like I said, that quad can turn into a bowl of mashed potatoes real quick. And that's a big problem when you make all your money by squatting big weights, right? You need your quads. So, we did everything in our power to maintain her quads as much as possible. And one of the big weapons we had against atrophy was neuromuscular electric stim, right? So, use electricity. The way I describe to my patients is that electricity is kind of language of muscles. We get the muscle to wake up a little bit by using the electricity for biofeedback to get that muscle to contract. And we use blood flow restriction training as well, which I usually wait for around 2 weeks to start. And I want to make sure the surgeon is okay with it. Okay. In terms of exercises, we're doing blood flow restriction generally at the start. So that means higher reps, 30, 15, 15, 15. I think it's important that you don't start with that many reps because if you take a knee fresh out of surgery and ask it to do a billion reps, probably going to be pretty sore, swollen, and painful afterwards. So I start with around 3 sets of 10 and I just work my way up. I like the high repetitions too because I think that's helpful from a motor control perspective. We're trying to establish more control within the muscle. So if you get a lot of repetitions, you get a lot of time to practice that. So I think the BFR combined with NMES is phenomenal as a treatment. What kind of exercise did we use? A lot of quad sets with the heel propped up to get that extension. We did a whole lot of straight leg raises. We did a lot of long arc quads and a lot of supine knee extensions. So we just did a ton of quad work early on and just make sure we're not pissing the knee off too much. We're not losing range of motion along the way. In terms of accessory exercises, so trying to work the glutes, the hamstrings, the calves as best we could. So that would be some sort of calf raise against the band, not putting too much weight through that knee because we're not supposed to be weight bearing quite yet. Standing knee flexion. I think we actually started that close to week 4 just because I was a little concerned about that attachment to the meniscus. Standing hip extension and abduction versus the band. So basically you have your athlete standing on the uninvolved side, got a band around the knees. You're doing abduction, extension. You can even do flexion in that position just to train the musculature around the hips as much as possible. Now, I really like telling my athletes this after they have a surgery, right? I like to say that we're basically going to war on the quads, right? And I have an image here of Chrissy's legs. So basically, you can see her quads at the start of her rehab. And this is actually at around week 6 when we're able to weight bear and try to squat. Take a look at her right side leg. You can see the difference in size of her right side leg versus her left. And actually, her left side is quite a bit smaller than it was prior to surgery. If you take a look at the image to the right of that, this is Chrissy's legs 7 months after surgery. And you can see that right side leg has really filled out, and the left side leg is quite a bit bigger than it was initially, too. So I think it's super important that we really hammer the quads as much as possible. So we're doing physical therapy twice a week. We're doing BFR, we're doing NMES. And then on top of that, we also have a home program that I want her to do on a regular basis to try to get those quads back in gear, right? So we're working on regaining motor control, slowly building up a little bit of strength. So my guidelines are 2 sets of 15, 25 repetitions of each exercise, 2 to 3 times per day, adding some light loads as able. So same exercise we just talked about that we did in the clinic, we actually do at home. And if they're being tolerated really well, we can add some light weights. It's important to keep things light at this point just because you can overdo it. You can get things pretty sore, especially if you're doing it at this high frequency, right? So that's going to be quad sets, straight leg raises, longer quads, and supine knee extension. So weeks 2 to 4, our patients are still non-weight bearing. However, we still have one additional limb that we're able to weight bear on. And I think it's really important to try to strength train that, right? We don't have the same research in meniscus repair patients, but in ACL reconstruction patients, if you work the contralateral limb, you actually get a significant improvement in strength, up to 40%, which is kind of crazy. So the non-weight bearing side improves by training the contralateral side, okay? So what did we do for Chrissy early on in her rehab? We did single-legged deadlifts, single-legged squats, and calf raises, right? So essentially, we tried to train the contralateral limb as much as we were able to. Do keep in mind that after surgery, the contralateral limb, the unaffected side, has to make you travel from place to place, okay? And it's the only limb that is doing that, okay? I mean, you have the crutches, your upper body helps a little bit, but basically, the left side leg was doing all of the work. And I'll tell you what, it can get a little sore. Sometimes folks end up with knee pain, hip pain, whatever type of pain on the contralateral side just because it's doing so much work. So, yes, you definitely want to train the contralateral limb. Just have to be a little bit careful because if you do too much of that, it can be more sore, more painful, create some other problems on the other side. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain-Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay, so a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a Fitness Pain-Free Mini Course. Definitely check this out.